my colleagues. My name is Barham Abu Dayyeh. I'm a consultant in therapeutic endoscopy and the director of advanced endoscopy at Mayo Clinic in Rochester. I'm also a professor of medicine over there. It's a pleasure to talk to you today about bariatric endoscopy. I'll give you my perspective on the field, but really the whole theme will be paving the way for a new field in endoscopy, which is this bariatric and metabolic endoscopy. These are my disclosures. Before we start talking about these different devices and procedure, it's important to highlight the unmet need in this space. Obesity, as you know, has reached wide world pandemic proportion. And unfortunately, despite the magnitude of the disease, less than 1% of patients who qualify for an intervention like bariatric surgery gets one. And the same number is for those who qualify for an intervention like a medication to treat excess adiposity or obesity. So the vast majority of the disease burden is unmet. In addition to that, it's important to highlight that patients with mild to moderate forms of the disease do have increased relative mortality because of excess adiposity. And we're talking now about a cohort with a BMI of about 28 to 34. As you could see in this study, their relative mortality risk was increased compared to BMI of 25. And this group with mild to moderate form of the disease do not have any effective intervention at this current time. Therefore, the field of bariatric and metabolic endoscopy has been developed in order to offer an anatomy-preserving, minimally invasive, effective option to bridge the gap between medical and surgical therapies. So endoscopic bariatric and metabolic therapies, the birth of a new field, where we are in 2021. We're going to start by talking about these devices. We're going to start talking about gastric devices. And with these, we'll start with the intragastric balloons. Intragastric balloon in a form were introduced to the market in 1980s. However, the design was limited, and the first balloon, which was called Karen Edward, failed because of increased risk of complication and the fact that it was air-filled, so it did not produce significant weight loss neither. Over the years, there has been a development of multiple newer balloon designs. Many of them have gained FDA approval through pivotal trials, and currently this is the landscape of balloons. We have a single fluid-filled balloons. We have a double fluid-filled balloon that currently is not being marketed. We have a series of gas-filled balloons that are swallowed in sequence and they're removed endoscopically. Then we have the adjustable gastric balloon, which is the SPAS-3, and then we have a balloon that's swallowed and excreted without the need of endoscopy, and it's also a fluid-filled balloons. So given that we're looking at a whole spectrum of intervention, I'm not going to be able to go through the nitty-gritty details of each of the intervention, but suffice to say, as a group, the intragastric balloons seem to produce about 10% total body weight loss at the time of their explantation, which is between 6 months to a year. And that's a significant improvement compared to lifestyle and sham arms. It's important, however, to understand the mechanism of action of these devices, because that have implication of how we could start tailoring therapy to increase success and minimize side effects, and to study their impact on comorbidities. Therefore, I would like to spend some time on this important area. So for intragastric balloon, we have learned through doing a sub-study as part of the randomized controlled trial of the single fluid-filled gastric balloon, that this balloon results in weight loss through a combination of alteration in gastric emptying and the fact that there's a space-occupying device within the stomach. But out of the two, the delay in gastric emptying seems to be the predominant mechanism of action. And here you could see in the blue figures is the intragastric balloon versus red, which is the control arm in the trial, you could see that the intragastric balloon results in significant delay in gastric emptying during the indwelling time, and then the gastric emptying returns to baseline after removal of the balloon. So what's the implication of understanding this important mechanism of action? The implication is that we could start utilizing this to enhance tolerance of the balloon. We know that gas-filled balloons are associated with the increase in tolerance and potential risks associated with recurrent nausea and vomiting attacks. So with this knowledge of the physiology of how they or their mechanism of action, we designed a pragmatic trial where we said we're going to utilize a baseline gastric emptying to eliminate those with baseline delays in gastric emptying from getting an intragastric balloon and focus on those with normal or rapid gastric emptying at baseline. And utilizing this approach of utilizing gastric emptying at baseline resulted in improved intolerance of the balloon from 12.5 to 4%, which translate to improved patient experience and less side effects profile. Second is knowing the mechanism of action help us devise better effective devices. And this is a meta-analysis that looked at the impact of the intragastric balloon on the delay on gastric emptying. And you could see that fluid-filled gastric balloons have more delay in the gastric emptying compared to gas-filled gastric balloon. Therefore, we could utilize this fact in order to tailor the choice of the intervention per patient. Those who have less weight to lose, and we want to focus on safety of the intervention, they could be triaged to air-filled or gas-filled balloon. And those who have more weight to lose, we could triage them to a fluid-filled balloon. And finally, knowing the physiology help us devise or innovate new intervention with focus on tolerance and efficacy. And with that, we have the adjustable volume gastric balloon. This is a device called the SPATS-3 balloon that allow you to start with a smaller volume of balloon in order to enhance tolerance. And then during therapy, it allow you to increase the volume of the intragastric balloon to increase the efficacy and the durability of the weight loss. In a randomized US controlled trial that's soon to be published, we've shown that the upward adjustment of this intragastric balloon resulted in about 5% extra total body weight loss compared to the non-adjusted arm. And then the downward adjustment of this balloon allowed for improved tolerance and avoidance of early removal in about 75% of the cohort. Therefore, the concept of utilizing physiology in order to enhance response and decrease side effects profile is an important one. And this is coming from the randomized controlled trial that I was referring to. You could see that compared to baseline, the intragastric balloon has an increase in the T-half or time to empty half of the ingested meal. That's significantly during the gastric emptying. And then upward adjustment after we reach plateau in weight loss resulted in an increase further in gastric emptying and further weight loss, which was about 5% extra total body weight loss compared to the pre-adjustment weight. Second, it's very important to evaluate the effect of these intervention on comorbidities. And here we use the intragastric balloon to evaluate its impact in a prospective study on histological NASH parameters in 21 patients under an FDA IDE study. And we've shown that the intragastric balloon implantation resulted in about 90% of NAFLD patient or NASH patient having improvement in their NASH activity score. 80% of the cohort improved more than 2 points, and 50% had regression of fibrosis by 1.5 stage based on MRE. Therefore, we demonstrated using gold standard histology as a proof of concept that intragastric balloon could have significant impact on non-alcoholic fatty liver disease and should be part of the spectrum of care. So what's the future of intragastric balloon? The future that they are a very good weight loss device. They need to be combined with lifestyle intervention and pharmacotherapy in order to enhance their durability. And this combination of a balloon for weight loss and remission of comorbidity, plus a medication for weight maintenance is going to be the key moving forward with this technology. All this has been now integrated within guidelines and white papers published by the American Journal of Gastroenterology, and now a clinical review that focuses on the gastric balloon is going to be published in Gastroenterology, detailing that this is a recommended treatment as part of a spectrum of care, provided that there is adjunct support for the patient in the form of lifestyle intervention and pharmacotherapy. More to come on this field. Now, what other intragastric devices we have in the armamentarium? We have a new device called the FullSense device. This is a modified, fully covered esophageal stent with a gap connecting to a gastric disc. That this gastric disc places pressure on the mechanical receptors in the cardia, thus tricking the brain that there is that the stomach is full, and hence the name FullSense. You could see here's a laparoscopic view of the device. The stomach in a fasting state is collapsed, but there is an umbrella effect on the cardia, thus tricking the afferent vagal nerves into the brainstem that there's food in the stomach. Therefore, the patient could consume less calorie. This device is cool because it works without food. You don't need to eat to activate the mechanism of this device. Therefore, strategies that utilize intermittent fasting with the effect of intermittent fasting on ketosis could be enhanced by a device like this and the metabolic benefit that comes with such a strategy. Here again, we have a quick endoscopic view of the device in place. You could see that the GA junction is not bridged, therefore the LAS is fully functional, and there is no significant GERD associated with this device. Here is the esophageal portion of the device. Now we're gonna go in the stomach and retroflex, and you could see now this is the gastric portion of the device exerting or activating the mechanical receptors in the region of the cardia to indicate fullness. The last category of devices in this group is the Aspire Assist, which is a modified PEG tube that allows the patient to aspirate about 30% of the ingested meal after each meal. With that, we conclude a discussion of the gastric devices. Now we shift gear to talking about the gastric remodeling techniques that we have. And it's important to highlight that despite multiple space-occupying devices, we still have a gap in the management of obesity because we need intervention that persistently produce more than 10% total body weight loss, because this threshold seems to be associated with remission or significant improvement of the majority of the comorbidities associated with obesity. Therefore, where we need to push the field and operate, we need to operate in the circle where there is significant weight loss close to surgical weight loss, but in an anatomy preserving, minimally invasive and accepted fashion to patients. Therefore, we have to be in this area, and we're hoping that endoscopic gastroplasty techniques are pushing us in this zone of operation as part of the intervention. One of these interventions is the endoscopic sleeve gastroplasty. Again, the first cases were described in 2012 with Christopher Gestout from Mayo Clinic. And since then, there has been a significant uptake and interest in this procedure as seen by these Hey Google search over the years. So, because this seems to be a procedure that patients accept because it's anatomy preserving, they tolerate better than space occupying devices, and it has more durable weight loss than the space occupying devices. But it's very important to highlight the importance of physiology when we design these interventions, because there has been multiple gastric remodeling techniques before and they have not been performed well. Therefore, when this procedure was being developed, we focused a lot on understanding what's the optimal physiologic shape of the stomach. Not what technique, not what technology that we use, but what's the optimal shape to induce weight loss. And we came with the concept of invagination of the greater curvature of the stomach, starting at the incisura and leaving a small pouch in the fundus, which goes against common wisdom. But with that, we show that this shape affects the accommodation and the emptying of the stomach to induce weight loss. So if you look at gastric emptying, and this is actually a picture is worth a picture was worth 1,000 words, you could see that at baseline, when a patient ingested a radioactive meal, most of the meal emptied at about 180 minutes into the small intestines. Very little remained in the stomach. 3 months after the endoscopic sleeve gastroplasty, you could see that at 3 hours, very little of the meal have emptied to the small intestines, and most of it is sitting in the small fundic pouch, thus activating the mechanical receptors to the afferent vagal nerve to the brainstem, indicating fullness and delaying gastric emptying, thus enhancing satiety. And then this becomes the concept is not what suturing method or what suturing technique we use, it's about the structure serving a function, and with that, this is the structure. It's a funnel-shaped imbrication of the greater curvature, leaving a small fundus. And as you could see in this MRI image, this is exactly what we're doing. This is the imbricated greater curvature of the stomach, and there is the small fundus pouch, and you could see that the stomach is preserved, its function is preserved, its anatomy is preserved. It's just it's delaying gastric emptying, affecting gastric accommodation, thus impacting satiety and satiation without increasing the risks of GERD or without having excessive symptoms. Thus, the patient tolerates this procedure very well. Now, there's been an increasing large body of literature that discussed the endoscopic sleeve gastroplasty. This has been summarized in 2019 in this meta-analysis showing that at 12 months, there's about 17% total body weight loss with serious adverse events rates of about 2%. This has been replicated in another 1,800 patient series coming from Brazil, showing about 18% total body weight loss at 12 months with a very low serious adverse events of about 0.8%. The durability this is from Cornell with Dr. Sharaiha, the durability of this procedure, if combined with an appropriate lifestyle program, seems to be extending up to 5 years, and there is a clear impact on comorbidity as well. The final litmus test will come from this MERIT randomized trial, which is a large US-based trial that is completed, and now we're in the result analysis phase. So hopefully this will move the needle forward in even more adaptation of this technique. But again, the structure serving the function is what's important. Therefore, we now could create an endoscopic sleeve gastroplasty with other technology, similar like, for example, the USGI platform that use these plications in order to imbricate or in order to result in a plication of about 7 centimeters. This post 2.0 procedure does a similar structure of the stomach, but it could be, the learning curve could be easier, and these plications could also increase the durability. It's still to be proven, but this is the concept of the post 2.0, again, using these plications in order to take a significant portion of the stomach and create a plication. Each plication we use here is about 7 centimeters. These plications are placed in a synchronous order, starting from the incisura and marching all the way to the cardia of the stomach, creating a tubular structure with a small pouch in the fundus, similar to what you would see with an endoscopic sleeve, but using this technology again that could enhance the durability of the technique. And this is, again, this is the picture of the stomach. So what we've done here is the stomach before, this is stomach after. We decreased the diameter of the greater curvature of the stomach, created a small pouch in the fundus, and shrunken the longitudinal length of the stomach as seen in these pictures. And this is the 6 months follow-up. Other development in this field, again, now using technology to kind of more streamlined adaptation of these technique. This is the nitinose automated suturing device that uses vacuum and uses automated suturing in order to do a similar thing, imbricate the greater curvature of the stomach, delaying gastric emptying, affecting the accommodation of the stomach to have the end results of increased satiety and satiation and weight loss. So if we put the endoscopic sleeve gastroplasty in the spectrum of care, and we said 10% total body weight loss is the key, you could see that it's augmenting the spectrum of care, and in about 75% of individuals, these gastric remodeling technique results in about 10% total body weight loss. Now we're going to switch gear to duodenal intervention. I know Dr. Kalapala will talk more about these interventions for diabetes, but it's important to highlight that the duodenum is an important regulator of metabolic control and inflammation. And this is an insulin resistant versus insulin sensitive duodenum. You could see that the microbiota is different. The length of the crypt to villus ratio is different. The stem cell niche within the crypts is different. And the neurohormonal milieu at the level of the afferent terminus of the nervous intervention is different. So the question, could we take this insulin resistant duodenum and reverse course on it to make it insulin sensitive to better orchestrate a metabolic response for treatment of metabolic disease and type 2 diabetes? This has been the target of multiple intervention, including small intestinal bypass devices. These are the liners that you place in the duodenum to bypass the first 65 centimeters of the duodenum. There's a different forms and iteration of these. And then there's ablative techniques that takes this diseased duodenal mucosa, ablates it, whether using laser, heated water, or now the newer kid on the block using athermal ablation with electroporation to have a metabolic response on fatty liver disease and diabetes. And then there is the biliary diversion, which creates a magnetic anastomosis either between the duodenum and the ileum or between the jejunum and ileum to divert bile for this metabolic response. So the future, in my opinion, the future is we have gastric pathways governing satiety and satiation, producing significant weight loss. We have small intestinal pathways and bile acid circulation pathways that impact metabolic processes that could be targeted for treatment of diabetes and metabolic disease, such as fatty liver disease. The key is combination of these interventions in order to produce significant and durable weight loss. And one of the coming devices in the future is doing just that. This is a single anastomosis endoscopic gastrointestinal bypass system that creates a connection using ultrasound between the stomach and small intestines, occlude the pylorus to delay gastric emptying, and divert food away from the duodenum, thus replicating both the gastric and the small intestinal benefits of these interventions in one simple device. The other is combining these interventions with effective medication. Semaglutide is the new GLP-1 agonist, and again, showing a lot of promise in weight loss and metabolic improvement. Taking these devices and combining them with medication is going to be a significant part of the future. Finally, what's going to allow us to even propel this field forward is the introductions of robotics that allow us to streamline some of these procedures and tackle more complex interventions, but that's going to be part of the future as well. With that, I will conclude summarizing that the GI tract is front and central in weight and metabolic regulation. Endoscopic, bariatric, and metabolic therapies will play a major role in the management of obesity and its metabolic complication. The future in this field is bright for endoscopy. We should embrace it, we should learn it, and we should push it forward. And I would like to thank you for your kind attention and answer any questions that you have.
Hello everyone, I'm Dr. Rakesh Kalapala from AAG Hospitals, Hyderabad. I thank for SGI and the organizing secretaries, Dr. Avinash and Dr. Manoj, for giving me this opportunity. Today, I will be talking on the future of endobariatrics in diabesity or diabetobesity. So I would start my talk now. So after the previous talk by my previous speaker on what is the current scenario of endobariatrics in obesity, so now we thought I'll just give you a futuristic idea of what's going in this field of bariatric and metabolic endoscopy. As you see here on the screen, you have the gastric devices and the small bowel devices. Few of them have been touched base by my previous speaker. So primarily what we have to remember is weight loss with metabolic effects dependent on weight loss or the gastric devices components, and metabolic effects independent of weight loss, but with some weight loss may be seen in people with small bowel devices. So what's happening here is, as you see on the screen, there are a few of the devices which are FDA approved, and then few are there in the pipeline which are going to be approved by FDA or the CE mark. So if you come to the gastric bariatric therapies on space occupying device, that is balloons, we all know it was previously also elicited about the liquid and gas filled balloons. Typically, the total body weight loss is between 6 to 12% in various studies published earlier. I would touch base upon the two balloons which are now going to be there in the future. This is the Obalon balloon, as you see on the screen. It's being played. It's just a capsule kind of thing which the person swallows. It gets into the stomach, interacts with the gastric juice, and then it will inflate itself and then opens up and creates a volume in the stomach, thereby compromising the gastric volume. So this typically has got the nitrogen gas mixture, and you can put 3 balloons at one after the other, and then endoscopically you can remove after 6 months. Of course, you have to take it out endoscopically, but you can ingest it just like a normal capsule. So to overcome that, the next one which has been designed and which is probably coming even into the Indian market is the Allurion. This is, as you see the animation video, very interesting and very exciting. So you see the capsule being ingested by the patient. As it goes into the stomach and gastric cavity, it interacts with the gastric juice, and then it swells up by getting self-inflated. And after 6 months, when the volume of the stomach is being compromised by this balloon and there is a weight loss, what happens surprisingly is there will be a self-disintegration or a self-destruction of the balloon, which will happen on its own, and then it gets into the small bowel and then passes off in the feces. So this is one thing which is very fascinating, and probably it is like you don't have to come to the hospital and then just sitting in the office, you swallow the balloon, ingest, and then after 3 to 6 months, once you have the achieved weight loss, it gets out of the fecal matter. So this is a very exciting field in the balloons. And the third one, which many of us know, and recently we are adapting it, is the adjustable balloon. The advantage of this compared to the previous balloons is you can adjust the balloon, the amount of volume you want. Suppose the patient is intolerable, then you take out 1500 ml. And if there is no desired weight loss, then you can ingest more of around 100, 150 or 200 ml, so on and so forth. So the maximum volume up to 900 ml. So the advantage of the adjustable balloon is there are a few studies which have been published in literature, which showed that after 6 months, the weight loss is more compared to the static balloon, which is non-adjustable. So on this basis, we started a clinical trial in our institute on the effect of this adjustable intragastric balloon in NASH patients. And we are also doing a study with paid biopsies of liver by using a US guided FNB. And the outcome of this we will have shortly in the next couple of months. So another one which is very interesting in the space occupying devices in the stomach is Gelesis 100 pictures. So as you see here, this is just a Gelesis, it's a capsule, which if you ingest it into the stomach, it will get inside, and then the capsule gets disintegrated into multiple particles which occupy 40 to 50% of the stomach. And these enlarged particles increase the volume and elastic response of the stomach, thereby without adding calories. And you take it 15 to 20 minutes before the meal. And once this occupies 40 to 50% of the stomach, obviously you don't feel eating more. And after that, these particles get disintegrated into, and once they enter the large bowel, the water is being absorbed, and these gel particles will get excreted in the fecal matter. So look how fascinating it is. And it is also, again, approved by FDA, and probably we'll try to get soon into the Indian markets. Now, after these balloon occupying devices, there is another new kid in the block, that is automated gastric plications. It's called EndoZip. It is from the company based out of Israel. So it is a fully automated, more operator dependent endoscopic suturing. You don't need any training in this, because it's self motor driven. So as you see on the, I'll just play a video. I'll try to go fast because of lack of time. So this is how the device looks outside. And once you put the device inside and then start the suturing, as you see here in the animation, the stomach tissue is drawn towards suction. There's a suction inside inbuilt, and it will draw the ports inside, the mucosa inside, then enables opposition of the gastric walls, and then it starts suturing, self-suturing. The helical needle is activated to automatically connect the anterior and posterior walls. So there's a study done by one of my close friend, Lopez Nava from Spain on this. And as you see here, it is having a good endurance, because it's done with a machine, unlike a manual thing where we do the fundoplications. So this is how it looks, and this is an ex vivo model which has been tried. Then they have done 10 first-in-human studies from the Spanish group, and they also published the short-term data on this. So this is how it looks, as you see on the screen. So the motor-driven plicating device will do its job. You just have to put the device there, and then it starts grabbing the mucosa and then suturing the mucosa. So this is the way it looks. And the published study from that group has shown, they have taken BMI between 30 to 40, and at 1 and 6 months, they have had a total body weight loss of around 11 kg, 10% to 36%. And they have had a short-term data, but let's see how this evolves in the long-term future. Now coming to another modality in the stomach, that is effectiveness related to anatomy and physiology. So I just want to have a gross physiological view of how this device, which I'm showing in the next few minutes, is going to work. As you see at the gastric cardia, there are multiple mechanoreceptors, and the theory behind this is if you exert pressure or stretch the mechanoreceptors, that causes early satiety, that is sensation of fullness, and that leads to less eating habits, or the binge eating will be prevented. So based on this, we started working on this full sense device, the bariatric stent, which is like a typical esophageal self-expanding metallic stent. What you see on this screen is a modified esophageal stent concept. What it has been done is we have taken a thread, which is the gastric area, and then esophageal lumen stent. And as you see here, building up this stent, which has got a delivery system. And this delivery system will be put inside, intubated along with a pediatric scope. And then we release the gastric end of the stent and then the esophageal end. Then it is anchored with sutures. I'll just show you in the next video how it looks. So this is the controlled delivery system, which has got the over the scope with like an over tube, and then it has got a staged release. So this is how it gets released. I'll show you a video how it looks. It is done in general anesthesia on endoscopic direct visualization, and it is deployed just like esophageal stents. As you see on the screen, we have done the first in human studies in the world, with Barham and me being a part of this study. This is a device based out of Michigan. It's from a company called BFKW. As you see here, the distal end of the stent is released in the stomach. It creates a gastric stud-like thing, and then the proximal end of the stent is sutured or anchored using the Apollo overstitch device. So you put 3 sutures in the proximal end, and in the distal end 1 suture, which will create that mechanoreceptor pressure on the mechanoreceptors, thereby leading to early satiety. So this is how the stent is put, and when you retrovert, it looks like this. So after this, we usually keep this device for 6 months, which leads to weight loss and also early satiety. And the removal also is pretty much easy. The implantation, it requires around 20 to 25 minutes. And for the explantation, we just have to cut the sutures on the proximal end, 3 sutures on the proximal end, and then the distal suture. So as you see on the screen here, I am first taking out the stomach part of the device. You just have to cut it with a coag forceps, and then it gets detached from the mucosa. Then you come up and then cut the sutures on the proximal end, as you see here. And once these sutures are cut, then there is a lasso with which you can explant the whole device in just probably 5 to 7 minutes. So we did this study in first in human study in 10 people. And after the device is explanted, as you see here, you have a little bit of mucosal edema and swelling, but they all come down, and there's no evidence of any perforation or any damage to the underlying mucosa. The proof of concept study was done in Mexico, and then in India, before the FDA trial execution, we have done this short first in human studies. And what we have observed in these 6 months implant is about the weight loss, the total body weight loss, excess body weight loss, then reduction in the parameters like HbA1c and also the liver enzymes. And what we have found in this study is there is a good amount of improvement of around 15 to 20% weight loss in terms of obesity, and also improvement in the AST, ALT parameters as well as HbA1c. So we have now got the investigation exemption device for a FDA trial, which just recently applied. And hopefully this is going to be again a new kid in the block of treating obesity. Now coming to the, this is one thing which I closely work with about diabetes, obesity, and NAFED. So this is probably the main need of the hour in our Indian scenario. As like the COVID pandemic, these two also are the pandemic areas of pandemicity in Indian scenario, for that matter, all over the world. So what can you do in people with the diabetes and obesity, diabesity or diabosity? So with this concept, as you all know, the small bowel therapies currently in vogue are the endobarrier, then you have the Valentex endoluminal bypass, then you have the DMR, then you have the magnetic incisionless anastomotic systems. I'll just go through this in the next few minutes. So as you see, one thing what we have to understand before going into this topic is why these sleeves or the duodenojejunal bypass liners have been created. As you see in the upper small intestine, the food is channeled to a liner, and then it does not contact the wall of the small intestine, which leads to increase in the plasma bile acids, and also there is alteration of neurohumoral signals. Whereas in the lower small intestine, these secretions flow around the liner and then mix with the food further down the intestinal tract, which increases the GLP analogs and peptide YY secretions. So based on this physiology, the duodenojejunal bypass liners they're working on. And what happened is in the first endobarrier study, there was significant improvement in the weight loss as well as glycemic control. But unfortunately, this device having had some liver abscess complications was withdrawn by FDA. So based on this, then in 2017, 2018, we thought of creating a device which is more robust, more safe. And that's how the endosleeve concept came into our minds. We started working with a metamorphics company based out of Minneapolis, in which Barham also is equally involved in that. So we started developing an anchor, which is a pyloroduodenal stent kind of thing, which will anchor at the pyloroduodenal area with a sheath which covers the first part of the duodenum up to 60 centimeters behind the papilla. So as you see on the animation video on the left side of your screen, this is the endoscopic delivery of this metamorphics endosleeve, which is very easy. And as I told you, this is a device which can be deployed by average endoscopists. That is a main area what we wanted to focus on. And if you see the animation video here, this is how the stent from the duodenal end is deployed. And this is the pyloric part of the stent. I'll show you how it looks exactly in a live human case. So you see here on the screen, this is where the capsule of the metamorphic sleeve is there. We have put it inside the first part of duodenum, as you see on the screen. Then the duodenal part is released, and this is the gastric part. So it gives a good anchoring with this. So this is how the sheath looks, and this will prevent the absorption of nutrients and thereby leading to weight loss and glycemic control. Retrieval also is pretty much easy. The stent has got a lasso which you have to catch, and then slowly you rotate the device so that the stent collapses and the whole stent gets into the capsule, and you just have to pull it out. And I'll show you the live human study again. As you see here, the stent gets collapsed once you pull the lasso inside, and then the whole stent gets into a tubular structure pattern and then gets into the capsule, which is seen here. So once the stent is inside, you just have to pull the sheath and take it out. So as you see here, hardly any mucosal injury. There are little superficial ulcers which are self-limiting. So this is how the endoscopic retrieval is done. So based on this, the results, what we have found in the first in human trials is the first 10 patients, there was a improvement of HbA1c by 0.4 to 1.8% with total body weight loss of around 12%. But not all, everything is as rosy as this. Yeah, as you know, all the startups in the world, 70% of them will not go forward, or rather 80% of them. So what happened in this is, it's not what is that rosy as I have shown on the screen. There are little migration issues happened. And because of that, we have to again go back to the bench side and then think of why this is happening. So with this, what we did was we tried to work on these migration issues. So we went back to the animal studies, then again back to Minneapolis from Hyderabad. And then we started why this is happening. So as you see here, the mechanism of the stent. So there is circumferential contraction of the pyloric antrum, and there is an off-axis contraction of the pyloric antrum. So with this, what's happening is the pyloric channel is such a robust, dynamic organ in the body. The contractions are just beyond our control. So that's the reason why even if there's such a sturdy metallic stent is getting bended and then getting into the stomach. So with this, what we thought is, let us have a basic pyloric sphincter physiology and see what is the physiological mechanisms of the pyloric sphincter. So with this, what we thought is, we'll do a study with the endoflip and then understand the basic physiology to develop or to kind of modify these stents. So then we have published an article in the Journal of JNM of the assessment of pyloric sphincter physiology using flip in healthy volunteers. And this is published in last year. So as you see here, this is the overall baseline cross-sectional area and distensibility index of the basic pylorus Indian people. So what we did is went back to the bench side, and then we developed a long over tube that reaches the pylorus so that the whole device will get into the pylorus. Then we did suture mechanism, suture tether, which I'll show you in the video, which you can better appreciate. Which is showing, as you see here, we created a tether which will anchor the device so that the migration will be prevented. So with this, as an animal model, we explanted after 1 month successfully without any migration. Hopefully, we'll be able to succeed in this in the next couple of months to make the duodenal sleeve into a next level. The other one is the endoscopic jejunal bypass or duodenal bypass, which is done with the endoluminal magnets. As you see here, this requires 2 scopes, that is a colonoscope and an enteroscope, which will be taken from the either ends, that is oral and aboral end. And as you see here, there is a magnet which gets deployed in the jejuno-ileal area. And after 6th day, the magnet will create a natural fistulous communication, which helps in bypassing of the duodenal lumen and then the food directly getting into from the jejunum into the ileum. So this is the dual path which minimizes the pressure on the magnet. And as you see here, that leads to weight loss and also the glycemic control. This is one study published by Christopher Thompson in the interim results. So another one is Valentex, which most of the people know about the gastroduodenal jejunal bypass with GI sleeve, which is a alike duodenal sleeve, but extends from the GE junction till the jejunum. This is again one study which is published on this, but it has to go furthermore because the tolerance capacity is difficult in this Valentex or the gastroduodenal jejunal bypass sleeve, and there are some complications in that. Another one which Barham is the creator or kind of mentor on this is the next generation Diamex, that is non-heat technology, unlike the DMR, which is a duodenal regeneration, which is again in the bench side. Hopefully that also will come into the commercial market in the next couple of years. So the dual efficacy of these GLB liners is in the metabolic outcomes is it will have a good amount of glycemic control, weight loss, and also a cardiometabolic improvement in the overall scenario. So just to conclude, as my last but one slide, endobariatrics should include the gastric and small bowel totally involved into, and this is the future. So as we all know, diabetes, obesity, and NAFLD or NASH is kind of a pandemic, and to address these issues, we should have some inventions in this field, and which will give us a better answer to this area of diabesity, which is perpetually going to be there in the long run. Thank you.
Thank you, Rakesh. Rakesh. That was a wonderful future perspective of diabetobesity, which is in fact the future of endobariatrics in India as well as across the world. So we have a few questions. Dr. Rakesh, there is a lot of talk on GLP-1 agonist. I think Barham is not here. Ideally, this question points to him. So, what do you think? What is the role of liraglutide? Are we at the stage where we can optimize the utilization of GLP-1 agonist along with ESG? And what is your protocol for using liraglutide?
Yes, GLP-1 analogs, they are going to be there in the future, Zahir. In most of our cases, especially who have the motivation is less post procedure, or who have higher BMI, like more than 40, we tend to do the ESG. Liraglutide is the drug of choice, and it has got a 100% established role. In fact, we are now waiting for the semaglutide, which is again, because liraglutide, the issue is you have to take every day. It has got little side effects in the form of nausea, constipation. So if the semaglutide comes into market, I believe it is coming in the oral form also, which is more acceptable. So GLP-1 analogs have a role, and they are definitely an add-on factor with good value addition in post-bariatric procedure.
And with this question, I'd like to involve Dr. Sridhar. Yes, Dr. Sridhar, please go ahead.
Hi, fantastic talk, sir. Good day to all. Coming to a fundamental question when it comes to endobariatrics, most of our tools and devices which we have targets entirely different concepts in physiology, like ESG targets volume reduction, the gastroduodenal bypass is a completely metabolic phenomenon. And when it comes to ESG specifically, we leave aside the fundal suturing, and the target on most of the papers, even in literature, target on gastric emptying rather than touching on ghrelin. As a person who has been involved in devising the fundal device, the full sense. So in comparison with ESG and full sense, if you club together, it would optimize weight loss, which is much higher than what we usually see in an endobariatric series, because our target is still under the mild to moderate category, and we still don't touch the super obese. But our instruments it's so plethoric, like the instruments available, it's so diverse. There is not a single stop shop for all. So your inputs on that, sir?
Yeah, it's a fantastic idea, Sridhar. I completely agree with you. I think probably once the full sense gets into the next level, so that is one area where we have to look upon. But of course, as I told you, if you can target both the stomach and small bowel, then you can address both obesity and diabetes. But as I said, it is a standalone obese patients. If the full sense comes into, then you put a full sense up. I mean, like you put a balloon, or you kind of do a ESG followed by full sense. And in that way, you can stretch yourself to the population of BMI even more than 40 also, the class 3 obese also. Yes, I completely agree.
Thank you, Dr. Kalapala. That was a fantastic presentation. So nice to see you again. So I wanted to ask you one question regarding practical issues in India. The way to go forward is combination of gastric devices and metabolic devices of the small bowel. But what would you think in Indian scenario would work, considering the cost issues and other practical problems we have, in combination of gastric devices, which is space occupying or restrictive, and small bowel metabolic devices? What do you think will be the future that we would be looking forward to?
See, if you ask me about the future in Indian scenario, I think the duodenal ablation devices or the duodenal jejunal bypass liners will have, one is more acceptancy. Second, probably that is one which we need to concentrate more on. See, we do have obese population.
Right.
You know, if you have some ablative techniques, especially in the duodenum, which are, reproductive, you can do it again and again. So that is one thing which we should look upon. But definitely with the pandemicity of this obesity and all, so you have to have the dual devices. And I hope our duodenal sleeve comes out in the next level. So that is going to be very affordable, and probably also the main aim is it should be done by any average endoscopist across the country. So hopefully that will give us some
Just a follow-up question. In terms of selection of patients, when you, notwithstanding the BMI of the patient and the expectation of the patient in terms of weight loss, when a patient comes to you, how do you decide on to choose the kind of device, the procedure that you're going to do, ESG versus, say, a gastric balloon? Is it only the BMI, or is it what physiology you determine the kind of procedure you'd opt for?
See, physiology in literature now, what they are following is do the gastric emptying and then decide whether he or she benefit with a balloon or a ESG. But because it's not done very commonly in our scenario, I rely upon the more of clinical material also. If the person is motivated and has got determination, then you offer him or her a gastric balloon. And if they are the people who are binge eaters who don't have self-confidence on themselves, then probably ESG.
Should we start doing gastric emptying studies before procedures, you think, now?
Yes. And that was symptomatic studies. Unfortunately, we don't have at all the centers.
Yeah.
It's an expensive affair in our scenario. But that is one thing which is going to be there as a futuristic thing. You do a GE, gastric emptying, and then decide on which device to be deployed.
Thank you.
On the same note, Rakesh, besides BMI, is there any other criteria that you use to send your patient to your bariatric surgeon colleague, or you are making it harder and harder for him to stay into business?
No. In fact, if the BMI is above 40, I blindly push my patient to the bariatric surgeon. So if it is only less than 40, we try to address. But again, more than 40, not fit for surgery or not inclined, then we take up.
Is it like, do you use balloon as a time buyer so that he is a candidate for ESG, and do you use it as a like sort of bridge
Yes.
so that he is?
In few cases, for the matter of fact, we have a very active liver transplant team. So all the liver transplant recipients as well as donors. So in fact, I was doing off-late balloons for the donors because once they have steatosis, they are not fit enough, or the post-transplant is not good. So my bariatric surgeon refers donors to me for weight reduction. And vis-a-vis in recipients also, we quite often put the balloons to have a weight reduction for the smooth post-operative course.
Similar line, sir. On a similar line on thought, being a transplant center, what kind of balloon do you choose, sir? Because the SPATS balloon has a suture material on the umbilical port, which is quite sharp in my opinion, a personal opinion. I'm actually honestly worried of rubbing against the fundal larynx or cause of a bleed or things like that. And what will be the usual protocol in such a potential recipient who we want to reduce weight, and we try a SPATS balloon and the volume, especially in an Indian scenario?
Yeah. So first of all, Sridhar, in that, what I feel very important is the case what you choose. If you have severe portal hypertensive gastropathy or severe GAVE or fundal varices, you better not attempt because you don't know what's happening inside. If you have only isolated eosinophilic varices, banded, fine, go with it. Then second, I think adjustable balloon is very good because in that, even if they have mild PSG or a little bit of GAVE, probably you can start filling it up to 400 and then eventually go up to 900 if it is tolerable. So I feel even with that SPAS balloon having that twig or tag, it's not going to really harm. I have experience of around 10 plus patients whom I have put, and none of them had any GI bleed or any side effects. So I feel in this particular scenario, adjustable balloon is good.
So 400 and escalate henceforth.
Yeah,
that would be your opinion.
Stomachs 400 to 450 is a good tolerance capacity, but even they can go further beyond.
Thank you, sir.
If you have fundal varices, I think it's better to avoid. Don't do.
And how is your experience with revision ESG, Rakesh? How frequently do you require it, and how do you choose about that whether this patient needs a revision ESG, and how do you choose those candidates?
We have a fairly good experience on the revision ESG. So one is, of course, weight regain after the lap sleeve gastrectomy. And second, some people, what happens after 1.5 to 2 years of LSG, they start regaining because stomach is elastic organ. The more you eat, the more that residual fundus expands, or residual pouch expands. So we have around, around 7 to 8 patients whom we did the post-ESG, post-revision LSG, post-LSG revision. And in fact, we also estimated by CT volumetry, pre and post pouch reduction. And we have almost around 10 to 15% weight loss in those set of patients. So revision, ESG in revision as in a post LSG is definitely a good modality, and we have to encourage that. It has got its own place. It's easy, it's an OPD basis. You just do it and then send them on.
Sorry to keep asking with questions. Since we have Zakir, Dr. Zakir here and Dr. Rakesh together, I would like to ask one question. Often patients ask, if I undergo ESG, what is the risk of developing a cancer, early gastric cancer, or developing a risk of cancer? That's a frequent question which we encounter, and I haven't got an answer to it. And especially with NBI and picking up of early gastric cancers and young people getting cancers, and I'm sure every suture is a full thickness suture, and the amount of fibrosis it undergoes is quite significant. And especially we're doing at young people who are 30 and 40 odds. So do we have any at least anecdotal evidence on it in this perspective?
Zahir, you want to take it up?
I have no idea. Sorry, Sridhar. I have no idea if these patients go on and whether detection is hampered or whether treatment is hampered. I have no idea because I haven't encountered myself. Neither
Right.
I'm aware of any literature which suggests that these patients how they behave, and I think it's mandatory that you do a good endoscopy before anything. Rakesh is always doing that.
Right.
He's screening these for early gastric cancers as well. I don't know if it's a part of he's just screening them, and of course he must be looking at if there are any precancerous lesions like atrophic gastritis or intestinal metaplasia.
Right.
I'm not aware if the presence of these precancerous lesions is a relative or absolute contraindication to perform ESG, but I'm sure that he must be taking these into account before he contemplates for ESG, and that must be a good answer. It applies more to Koreans and Japanese, where the incidence of early gastric cancer is very high, and for that reason they have a strict screening protocol. And I think this question must be pondering into their minds as well. And what happens if these patients go on developing in cancerous lesions, and how easy will it be to detect and subsequently to manage these patients? I think
Because the fundamental question was because the obesity and the developments are happening in the West, and the early gastric cancer scenario and NBI screening is happening in the East, and we are sandwiched in between these two. So we have everything here. So that's where we got sandwiched, I feel.
I think this depends on the place where you are staying, and this Americans and Europeans, they are more worried for obesity, and Japanese and Koreans, they are more worried for early gastric cancers, because I think their BMIs and the BMIs of Europeans and this part of Asia is quite there is a stark difference. And I think it depends on the place where you are staying in and how important is early gastric cancers in your part of world. And I think it goes like that. What's your take on this, Rakesh?
Yeah, I agree. In fact, Japanese and Koreans are not obese. Obesity is not that prevalent in that population. So ESG is not a real thing for them.
We don't see. I think I'm not aware of studies from that part of world, because they are probably not worried for. They are more worried for new techniques in endoscopic submucosal dissections and all, and that's why the developments in that part of world are more projected towards dissections and dissections. And whereas in if you see in US and Europe, they are more worried for this obesity pandemic, which is, I think, a bigger problem for them. But definitely, Sridhar, that this is something that needs to be taken into account before you contemplate ESG, and whether early gastric cancer detection and management will get hampered. I think it all depends on the benefits and risks that the incidence of early gastric cancers versus the incidence of obesity. I think the benefits.
Especially Barrett's is something that is not taken much into account, especially in endoscopic bariatric, which has a potentially high incidence, I believe.
Yes. In fact, this laparoscopic LSG has been criticized because the incidence of GERD is quite high. And if you compare ESG to LSG, I think the incidence of GERD is much less. So I think the chances of developing Barrett's in future also are much less with ESG as compared to laparoscopic sleeve gastrectomy. So in that way, I think ESG will score over LSG. So I think with that, we can conclude this session. And thank you, Dr. Mohit, Dr. Ananta Agasti, and Dr. Sridhar. It was a wonderful discussion. Dr. Rakesh, of course, he has been developing these new techniques that even I am not aware of what he has been doing all these years. So thanks a lot for sharing your experience, Dr. Rakesh, and Dr. Sridhar, Dr. Mohit, and Dr. Ananta. Thank you for joining this session. And with that, we conclude this session. Thank you all. Bye-bye.
Thank you. Bye.